Apologies for the technical issue. Good afternoon, everyone. My name is Unku Hanin, your host for today's SMCV's Virtual Antenatal Talk event. I hope everyone is feeling great and doing good today. Thank you for joining this virtual head talk today. We hope that this talk will be beneficial for all of you. So before we proceed with today's virtual head talk, let me go through the agenda with you guys. So we will have 4 consultants from Sunway Medical Center Velocity to talk about the early stages of pregnancy, as well as the care of your newborn after the baby is delivered. So just a note for you guys, please remember to fill in your details in a simple form attached in the Facebook comment section for your attendance, where the first 50 registered participants before 22nd February will get a free gift from us. Okay, moving on. Just to go through a brief introduction about Sunway Medical Center Velocity. So we are a new addition to Sunway Healthcare Group. We are a 10-story structure specially built to hold 240 beds and a total of 77 specialist clinics. So we are located in a part of an integrated township of Sunway Velocity, consisting mall, residence, medical center, and also college. We are located in Cheras, Kuala Lumpur, when we are 3.8 kilometers away to KL city center. As mentioned, we are part of an integrated commercial residential township consisting of residence, Sunway Hotel, Sunway Medical Center Velocity, and also Sunway Shopping Mall. A bit overview about our hospital. We have opened our door from 3rd September 2019. We have 10-story block and 240 beds. As mentioned, we have 45 specialist clinic. Some of the specialties that we offered here is anesthesiology, cardiology, ENT, general surgery, oncology, ONG, pediatric, and many more. We also have our own accident emergency department, our catheterization lab, chemotherapy daycare, delivery suites, and so on. Some of the photos of our facilities here. So our room rate starting from 90 ringgit for 4-bedded room, and also our premier suite is 1,288 ringgit. Some of the photos of our delivery room here. We also have our own neonatal ICU here. And to let you guys know, this is our new maternity package where we are offering 30% off of hospital charges. Next, I will be playing our corporate video before we welcome our consultants for the first talk.
Welcome to Sunway Medical Center Velocity, your multi-specialty tertiary healthcare provider. As one of our core specialties, our women's health offers a range of obstetrics and gynecological services to help women manage their health care, from family planning services, prenatal support to postnatal care, as well as mother and baby wellness. Every parent wants the best for their children. That's to the health of the little ones. Our pediatricians are here to help parents manage the different medical needs of their children at every stage of their lives by evaluating physical milestones, behavioral development, and providing regular health assessments and vaccinations. Health begins with the right preventive care. At our Health Screening Center, we can assess your health status and help you manage potential health risks by offering screening packages to suit your every need.
Apologies for the technical issue of the videos playing just now. I think I can start to invite our first speaker, which is Dr. Janani Selvanathan. Hi, Dr. Janani.
Hi, Haneem.
How are you?
I'm good. Hope you are good as well.
Yeah, I'm good as well, Dr. Janani. Okay, so without further ado, let me allow you to start the talk now.
All right. Okay. Thank you very much, Hanim. All right.
Mhm.
Hello, everyone. Nice to meet you all on this platform this afternoon. My name is Janani. I'm one of the obstetricians and gynecologists in Sunway. And my topic today will be bun is in the oven, what to expect in the early stages of pregnancy. Okay, so basically, just what my title means is like the bun is in an oven is meaning that the woman is expecting or she's pregnant, as in like the womb is a nice warm place for the baby to develop inside. Okay. Okay, so how do we know we are pregnant? Basically, we miss our period, and generally 4 to 5 weeks after that, we can do a urine pregnancy test. Sometimes there's also a blood test called the beta HCG to confirm the pregnancy. So basically, dual line or two lines seen on the pregnancy test kit would mean that the woman is pregnant. So, symptoms of early pregnancy, some women may feel extreme fatigue or tiredness, suddenly just want to sleep all the time, tender and swollen breasts, the nipples may protrude more evidently. There might be nausea with or without vomiting. So, some women only have nausea, but some have very bad vomiting. This is called morning sickness. There may be cravings that, certain foods that probably you never used to eat before, suddenly you feel like, I want to eat this kind of food. Mood swings, which is quite just general, frequent urination, heartburn is also quite something that lots of women experience. Headache, constipation, weight loss, if especially if there's lots of vomiting, or a bit of weight gain will occur after that. So what's important is once you've confirmed that you're pregnant, an early scan has to be done to ensure that the pregnancy is within or inside the womb, dalam rahim. Okay, so if that is called intrauterine, yeah, within the womb. Okay, because if the pregnancy or the kandungan is outside the womb or di luar rahim, okay, that is called ectopic pregnancy, and this can endanger the women's life. Okay, so other than that, uh, we would also scan to look for whether it's one baby or two babies or more than that. If the baby's heartbeat can be seen, and generally from 5 to 6 weeks, if we do a scan from below, a transvaginal scan, we will be able to see. Transabdominal, probably after 7 to 8 weeks, we can see the heartbeat. So what happens? Unfortunately, some women develop bleeding in early stages of pregnancy. Okay. So what are the causes of bleeding? So 80% of the time it is something called threatened miscarriage, where the pregnancy is in the womb. Yeah, that means dalam rahim, kandungan dalam rahim. We can see the fetus, the baby, and the heartbeat. So this is called threatened miscarriage. So usually not to worry, this thing will resolve. So we will just give some support for the pregnancy, some hormonal support, and 92% of the time should reach up to term. That means cukup bulan and the baby will be born. Okay. Sometimes the bleeding occurs because of miscarriage. That means the pregnancy is there, but the baby is not formed. That means kandungan tak menjadi. Okay. The other cause of bleeding is kandungan luar rahim or ectopic pregnancy, where the pregnancy is outside, and this is can endanger the life, so it needs to be attended to immediately. And the other thing is molar pregnancy or kandungan anggur, where the baby is also not formed and it's just tissue or vesicle-like formed inside the womb. So how do we go about these things? So like I mentioned before, if we can see the baby and we can see the heartbeat and you have a bit of bleeding, we will give you some pills, progesterone, to support the pregnancy, and usually it's given for up to 12 to 16 weeks. Okay. If we scan and see that there's no heartbeat, and then so there's an option of either just waiting or we can proceed with cuci, or we call it DNC. Okay, and the last is if it's a pregnancy which is outside kandungan luar rahim, we have to do an operation to remove the kandungan. Okay, sometimes there's also we can give some injections, or if the pregnancy is not so big, to avoid a surgery. Okay, why do I have cramps? Okay, so early pregnancy women can have cramps, which is something that generally they can experience. Next slide, please. Okay, and this can be due to the growth of the womb. The rahim, which was initially small and in the pelvis, is growing to come out of the pelvis. So ligament stretch can cause these cramps. Other than that, it can be due to constipation. Yes, as when we are pregnant, because of the hormonal effect, the intestine and the usus and all moves very slowly. So digestion and all takes some time. So we tend to get constipation, gas, bloating, okay, ligament pain, Braxton Hicks, urinary infection, fungal infection. So all this can cause the cramps. As well as, of course, the most important is to make sure it's not an ectopic pregnancy. Yeah. Next, moving on to in early pregnancy, the next thing is what medications can I take and is it safe? Yeah. So we would advise women who are planning to conceive to start taking folic acid before they plan to conceive, at least 2 to 3 months before. Okay, a folic acid of 400 micrograms, but generally the one tablet of folic acid contains 5 grams, so it's more than enough. For nausea and vomiting, can take drugs such as Maxalon or Veloxin. This is all safe. Gastritis and heartburn, you can take antacid like Gelusil or Gaviscon, Maalox. All this is okay. If we have fever, paracetamol is safe. If you've got flu, loratadine, cetirizine, all these are safe. Okay, cough syrup is also safe, and certain medications are started in early pregnancy, like aspirin, for sugar, like metformin, high blood pressure, beta-lopa. All these are safe, as well as progesterone support, like Dufaston, Nutrogestin, Cyclogest. These are all medications that are safe in pregnancy. What we need to avoid would be vitamin A, like retinol. Some people put that on their skin for acne, and vitamin C in high doses. This should be avoided because they are teratogenic. That means they can affect the baby. Okay, external radiation, and then chemicals. So try to avoid all these unnecessary exposure, and smoking, alcohol, and certain types of drugs, which like anti-epileptics. That means if there's a history of fits and they are taking certain drugs, you need to see the doctor to see whether these are safe to continue in pregnancy. Can I exercise in pregnancy? Of course, exercise is good and encouraged in pregnancy, provided you have been doing this exercise from before. Not suddenly when pregnant, I want to start doing exercise. Okay, so but if you haven't been exercising and then in pregnancy, you have to um, start slow. But if you have already been exercising, so then we would say continue doing your exercises. For example, 30 minutes a day, a brisk walk, or swimming. All these are good exercises, yoga, and they are all safe to be done in pregnancy. However, if you have certain types of condition, medical condition like heart or lung problem, cervical insufficiency means there is a weakening of the womb. Okay, and if you are having multiple pregnancy, that means with twins or triplets, okay, and at increased risk of early labor, then we would advise not for very strenuous exercises and to avoid exercises, as well as if you have pecah air ketuban, that means leaking, or you have a low-lying placenta, uri di bawah, should avoid exercise. Okay, and if you're very anemic, that means kurang darah yang quite significant. Okay. The other question is it okay to have sex? So in the second trimester and early pregnancy, it is fine to have sexual intercourse. It is not going to affect the pregnancy. However, it should be avoided if you have unexplained bleeding. That means the placenta is not low, that means uri is not bawah, or everything else is okay, but you have bleeding, or pecah air ketuban, that means you're leaking. Okay, if the pangkal rahim is lemah, okay, you have history of early labor. All these things we will also advise to avoid sex because it can cause preterm labor and things. It is also very important to have a good dental hygiene during pregnancy, and we would advise at least 1 or 2 visits to the dentist during your pregnancy, because if the dental hygiene is not good, this also can predispose to preterm labor as well as poor growth for the baby. So antenatal care. So what does antenatal care mean? That means once you are pregnant, you need to do antenatal care. You're booking at either the clinic kesihatan or with the GP or with ONG specialists like us here in Sunway Velocity. We will do the antenatal screening bloods to look at your hemoglobin levels, infectious status, HIV, hepatitis, syphilis and all that, as well as your blood group, whether it's the most important is whether the RH is positive or negative. Negative means we need to do give further tests and also give you NTD during the pregnancy. MGTT means it's the sugar test as well as a thyroid function test as a baseline later on in the second trimester of pregnancy. And routinely the urine should be tested for sugar as well as for protein at every visit, and your weight, blood pressure, pulse will be taken. They will also check for the baby's heartbeat and check and see if your legs are swollen. Okay, and a scan will generally be done to look at the growth of the baby, the water surrounding the baby, and vaccination in pregnancy, especially the flu vaccine and the tetanus, diphtheria, and pertussis toxoid vaccine should be given. Okay, so now coming to the scan, as I'm a maternal-fetal specialist, so in the first trimester, we do a particular scan called the first trimester scan. It is between the 11 to 13 weeks. And this is done so that we can accurately date the pregnancy, and mainly done also to screen for risk of Down syndrome. This test was brought about mainly to look for risk of Down syndrome. And other than that, also the first trimester anomaly scan. That means in that first trimester itself, when the baby is like probably 5-6 centimeters, we can check to see if the brain is formed properly, the heart and lungs, whether the hands, feet, and the tummy, everything is looking normal. The general first trimester scan is to look and see if there are any signs suggestive that the baby may have a genetic syndrome like Down syndrome. And this is done to look at the thickness behind the neck, that is called the nuchal thickness. So in babies with Down syndrome and some certain genetic syndromes, it will be thicker than normal, including if there's some lymphatic problem or heart disease, it will be higher than normal. And in Down syndrome, the nose bone will not be clearly seen. So with the scan, a blood test is also done, and in that blood test, they will put in the mother's age and all the demographics, and they put it into a calculator together with the scan findings, and it will give the risk of for the baby to have Down syndrome and two other syndromes, mainly Edwards-Hepatile syndrome. Okay, so this test is about 90 to 95% accurate. There is a new test which only looks at the blood, and in the blood, the baby's DNA will be there, and that can give the risk for Down syndrome as well as a few other genetic syndromes, and that is about 99% accurate. Of course, because this is the newer test, it is a bit more expensive than the first screening test. All these tests are obviously optional, whether you want to do it or not, but it is routinely done in the developed countries, but it's also available in our countries, and certain centers do offer this first trimester screening. So this is just an example of a Down syndrome baby, and if you can look at these genetic karyotype picture on this side, where you can see that usually it's all 2-2, it's a pair. So one from the father, one from the mother. So it's a pair, but when it comes down to the number 21, there is 3 as circled in the blue. So with the 3, the baby becomes Down syndrome. Okay, so the next thing that we look at is something called whether there is shortening of the cervix atau lemah pada pangkal rahim. So if there is such a thing, then we can either give medication to support the pregnancy, or stitch the womb, like put in a cerclage or a ring to help bring the pregnancy to near term. Okay, so this is just a scan to show example of how the first picture, that the pangkal rahim or the cervix is nice and long and closed, but in the next picture it is already open and the baby's head is almost coming out, and this was probably just at about 16-17 weeks. Okay. So other than that, in the second trimester, we will do an anomaly scan that's between 20 to 22 weeks to look at the structure of the baby. The baby is much bigger now, so we can see if the brain is formed properly, the face, if there's any cleft lip, and then we look at the heart, lungs, spine, kidneys, okay, hands, fingers, the gender, the placenta position, the liqua, the fluid around the baby, everything is normal, as well as the growth during the anomaly scan. Okay, so other than that, What's very important in the pregnancy is for the mom to bond with the baby. So you can start bonding with your baby from beginning itself. You can start talking to the baby because the baby sort of can hear you and know, get used to you. You can read to the baby, listen to music, and it's good to be in a healthy environment with fresh air, have nutritious food, drink adequate amount of fluids, exercise. Mental health is also very important, and have a positive outlook. Um, you can do what you like to do, painting, dancing, something to um, increase the mental as well as artistic activity, do yoga, and involve your partner and the family in your course of pregnancy. So it will be a holistic involvement of everyone and in anticipation of getting the new arrival of your baby. Thank you very much. It has been a pleasure. If there are any questions, I'm happy to take them.
Thank you so much, Dr. Janani, for sharing the very informative talk. So let's now welcome a Q&A session from the participants. If you have any questions, just key in, just type in the comment section below. Before that, I would like to remind all the participants to fill in your details in FB comment section, where the first 50 registered participants before 22nd February will receive a free gift from us. Let's just wait for a bit while before we can excuse Dr. Janani. Anyone, if you have any questions, just type in the comment sections below.
There are no
Okay.
questions. Everyone
Yeah,
understands.
the participants are shy. Okay, it's okay. Thank you so much, Dr. Janani, for your time today.
All right.
Okay,
Thanks. My name.
all right. So let us welcome our second speaker, which is Dr. Noor Eliana. Dr. Noor Eliana is our consultant obstetrics and gynecology consultant. She will share about vaccines in pregnancy. Are they safe? We'll just wait for Dr. Eliana to prepare. Hello, hi Dr. Eliana.
Hi.
How are you? Hope you are doing okay.
Yeah, very good. Thank you.
Okay, Dr. Eliana, without wasting so much time, let us start with your talk today.
Okay.
You would like to
Assalamualaikum.
share?
Yeah. Assalamualaikum and selamat sejahtera. My name is Dr. Noor Eliana Nordin. I'm currently working full-time in Sunway Medical Center Velocity in Cheras. So I'm sure you're having a good weekend at the comfort of your house. And the thing is about webinar, I like is you can multitask. For me, I just switch on the computer and I can do other things like probably eating Maggi or lipat kain. So it's very chill and santai. So without further ado, as scheduled, I am actually going to be giving a talk about vaccines in pregnancy. Are they safe? So vaccine is the in thing now because since you are getting the COVID-19 vaccine, I think this is a very relevant topic to be talking about today. So Hadim, next slide. So before I talk about vaccine, I just want you guys to know like what vaccine is. So vaccine, Hanim, next slide. Okay, vaccine is actually is a form of a weakened virus or germs that is being given to our body to trigger our defense mechanism. So the way I remember it in medical school is just like, oh, we have a bunch of army. We need to know our enemy first before we can actually fight them. So our defense mechanism is more or less the same. So let's say we are army, we have enemy. So if the more we know our enemy, the next time the enemy attack, we are more likely to win the battle. So vaccination is actually the act of giving vaccine. Okay, next slide. Okay, so there are a few types of vaccines. I mean, this is not meant to be like a medical school talk, so I've summarized all this. So the first one is actually live attenuated vaccine, meaning is a live vaccine, a live virus, like virus hidup, but it actually being weakened. So the wild vaccine being cultured many times is actually still living, but it's weakened and being given to us. Yeah. So for example, this kind of live attenuated vaccines are MMR, rotavirus, smallpox, chickenpox. This one cannot be given in pregnancy because technically they are still alive. Okay. So the second type of vaccine is inactivated vaccine. This means they are a true virus or germs. They are being heated and killed. And then being given example of these vaccines are flu, polio, and rabies. So this one can be given in pregnancy if needed to. Okay. And the third type is a subunit recombinant polysaccharide. So now we are having the COVID vaccine. The COVID vaccine falls into this group. Is actually part of the virus, subunit polysaccharide. So in short, it's actually is part of the virus, not the whole thing. Okay. So the example of these subunit recombinant vaccines are HIV, Haemophilus influenza vaccine, hepatitis, human papillomavirus vaccine, pertussis. So this one can be given in pregnancy. Last but not least, the toxoid vaccine, meaning germs, bacteria produces a toxin. These can be given as vaccine as well. Okay, next slide. Okay, I mean, in order for you to understand why we need a vaccination, we have to understand why vaccine work. So, like I said earlier, vaccine actually train our body defense mechanism to fight the germs faster. So, how does vaccine do it? So once one get injected with a vaccine, you can see the blue thing there. That's vaccine introduced into our body. Next slide. Okay, so this is the harmless form. If you remember the four types earlier, this is a harmless form. And the Y thing there is actually our defense system. That is our antibody. So put it, simply, is our first responder. So the three of them in this picture. So what will happen, it will trigger the other responder. When the first responder see this vaccine, it recognize, it learn it, and it make memories. So it will tell the other responder, okay, and then learn how to fight this virus. Okay, so next slide. So, and then it multiplies. So in pregnancy, this antibody that has been created after learning the vaccine is being transferred to the baby. So next slide. So the next time one get infected by the real enemy, the real virus, because the body has learned about the virus, it can act faster and more effectively because it has learned. So unlike for those people who doesn't have vaccination, when they get the infection, it is the first time ever our defense mechanism see the virus. So for us, like we are going into a war, we are army officer, it's the first time we saw the enemy, we see the enemy. So we will not know what their strength, their weakness. So it will take time for us to act. Unlike those people who had been vaccinated before, they've learned from the weakened form of the virus. So our body system will fight better. So hopefully after vaccination, we did not fall sick. So next slide. So vaccination in pregnancy. So I'm sure some of you had already know there are actually two vaccination that is actually recommended in pregnancy. So if you're already following up with your private GP or private obstetrician, they will recommend you to take two kinds of vaccine. The first one is Tdap. T stands for tetanus, D diphtheria, AP pertussis, as well as influenza. There are some other vaccines that may be taken in pregnancy in certain cases. Those are listed in pink color. For instance, if you want to perform Haji or Umrah, you are going to in the Arab countries, the endemic of meningitis is there. You can consider to take meningococcus vaccination. Okay, next slide. So what about COVID-19 vaccine? I'm sure all the preggy mommies there has got question, okay? So for now, our Malaysian government doesn't recommend COVID-19 vaccine in pregnancy. It is not because it's not safe. It is because in order for an organization to approve vaccination, the trial has to be done. Yeah. So for now, as I speak today, there are no trial of COVID-19 vaccine being done to pregnant ladies. So for now, we don't recommend COVID-19 vaccine in pregnant ladies. However, okay, that's however. To those who are working in high risk situation, let's say you are a healthcare worker working in an intensive care unit, taking care of COVID-19 patient, you have got no choice, so you fall into a different category. So discuss with your healthcare provider regarding COVID-19 vaccine if you're pregnant, if you fall into this category. Okay, next slide. Okay, next slide. Anil. Hanif, next slide, Hanif. Okay, so all right. Okay, so I did mention in pregnancy you're giving two types of vaccination, that is Tdap and influenza. So I just want to briefly tell you what like the tetanus, diphtheria, and pertussis is. Tetanus, in Bahasa we call it kancing gigi, or in English lockjaw. I think this one is a duplicate slide, but what it is actually it causes fit or sawan, a spasm in babies. So in nowadays, tetanus is uncommon because technically everyone already get vaccinated. Those time when vaccination is unavailable and as well as things are not sterilized, you know, when the umbilical cord is cut with non-sterilized scissors or knife, baby is at risk of getting tetanus. So next slide. And the next thing is diphtheria. This is an infection caused by bacteria where the babies can get sore throat and fever. In severe cases, there is a patch in the throat that can actually obstruct the airway and also disturb swallowing. So this can be dangerous to babies. So when a pregnant lady get the Tdap vaccination, to some extent the antibody will be transferred to the baby. So in the hope that while the baby first get their vaccination with Tdap in the second month of life, they are protected, yeah, while they are waiting. So the next one, next slide. Then P stands for pertussis. This is a whooping cough or batuk koko. So it's called whooping cough because when a baby have this, they cough non-stop. So they like and then whenever they get the chance to breathe in, they whoop. So that's why it's called whooping cough. This one can be dangerous, and I mean, like pity the baby to have this. So Tdap vaccination is protective against pertussis as well. So next slide. Okay, so when to vaccinate? So for influenza, it can be given at any stage of the pregnancy, okay? But I personally give after first trimester. And the Tdap vaccination is given after 28 weeks, up to 32 weeks. But if one is late to get the vaccination, you can still get the vaccination until up to 36 weeks. Okay, next slide. So the conclusion is, while some vaccinations are not safe in pregnancy, there are some which is actually indicated, mainly to protect the mommy as well as the babies. Okay, if you've got a question, don't be shy to ask.
Thank you, everyone. Before we proceed to the Q&A session, let me just remind you guys to please fill in your details in the Google form attached in the comment section below. Okay, doctor, so we can see the first question here from Unku Nabila. When can we take vaccine during pregnancy? I think you've mentioned before, maybe you can further elaborate on that.
Okay. Hi, Uncle. So there are two types of vaccination that are indicated in pregnancy. Dua jenis vaccination yang kita recommend dalam pregnancy, two types. Satu, first one is influenza. Influenza vaccination can be taken at any stage of pregnancy, meaning from first trimester up to third trimester. And then the second one that is indicated, recommended is Tdap, the tetanus, diphtheria and pertussis vaccination. That one is usually being given at after 28 weeks of pregnancy. Although in some places they can also be given after 20 weeks. And if you choose to do so, both of these vaccination actually can be given together. So answering your question, flu vaccination throughout pregnancy, for Tdap vaccination, usually after 28 weeks.
Okay, thank you so much, Dr. Eliana. We have second question here. Just now you mentioned about vaccine during COVID-19 vaccine during pregnancy, right? So Manik Tan, she's asking about how about breastfeeding mommy to take the COVID-19
This is
vaccine.
for COVID-19 vaccine, yeah?
I think so, Miss
So yeah,
Yeah.
pregnancy. Okay, so breastfeeding mummies. So for COVID-19 vaccination for breastfeeding mummies, as for now, it's not being recommended because, like I say, for us to for the organization to recommend something, it has to based on evidence. So for breastfeeding and pregnant ladies for COVID-19 vaccines, so far there's no evidence, hence not recommended. However, like I mentioned earlier, if you fall into a specific group, let's say a healthcare worker with direct who are actually working directly with COVID-19 patient, or social worker, people who work in a nursing home, those high risk, you can discuss with your healthcare provider about COVID-19 vaccine. If you ask about Tdap and flu vaccine, just flu vaccine in general, if you are breastfeeding, you can still get it, but flu vaccine usually is being given in high risk group like kids, adults above 65, pregnant ladies. Yeah, you can get flu vaccination. If you're breastfeeding and you want to get flu vaccination, yes, you can get flu vaccination.
Okay, thank you, Doctor. Moving on to the next question from Shakina Kushairi. She's asking for the Tdap vaccination. This can just be requested by our gynae, correct? I took my influenza vaccine before conforming my umrah back in Jan 2020. Do I have to take it again, Doctor?
Okay, yeah, that's right. Okay, so technically, flu vaccination is being given. Flu vaccination is being given yearly to high risk group. High risk group, like I said just now, like older pregnancy, older than 65 kids. You take flu vaccination actually yearly because they've got different strains of virus and yeah, and they've got different strain and it can come and go. And then for the TDAP, okay. TDAP vaccination, actually GP can also request. I've known certain GP who does antenatal checkup has had given TDAP vaccination before. So it's not necessary to be from private obstetrician.
Okay, hope it's answered the question. Okay, moving on to the next question from Miss Vivian. Can mommy take influenza vaccine at third trimester, Doctor?
Yes, yes, you can be it. Influenza vaccination, flu vaccine can be given throughout pregnancy, meaning first trimester, second trimester, and third trimester. Yes.
We have a few more questions, Doctor. Again, from Ms. Unku Nabila, what are the situation of the mummy that you will recommend for mummy to take? I am 32 years old. Which vaccine should I take at least?
I'm not sure if Engku is pregnant or not.
Um,
Uh,
she is pregnant now.
yeah. Okay. So the two that I recommended, generally recommended is the flu vaccination and the Tdap vaccination, tetanus, diphtheria, and pertussis.
Uh, by the way, that's my sister, so she's asking because I know she's pregnant now. Okay, Doctor. Okay, I think this is the last question from Miss Tanya. Should pregnant mothers wait until after delivery to take the COVID vaccine? If yes, the pregnant mother got infected by the COVID, do they still need to take the COVID vaccine, Doctor?
Okay, so she has got two questions. So
Uh-huh.
if you don't fall into the high risk category group, ladies, our government actually doesn't recommend a vaccination. So answering that, if you don't fall into the high risk category, meaning you wait until after delivery. Uh, okay, now the second question. If a pregnant mother got infected, after having the infection, okay, actually this one I'm not sure to answer. If the pregnant mother got infected, but they still need to take the COVID vaccine. Okay, I'm not sure about this question per se, but what I know, if one had got infected with COVID-19 before and they have been cleared with the infection, yes, they can still take the COVID-19 vaccination. But answering your question, pregnant mother got infected, I am sorry, but I'm not very clear about that. Yeah, because generally in pregnancy is not recommended yet unless you fall into a specific group. Yeah, the take home, don't get confused. So, with meaning, in pregnancy, we don't give COVID-19 vaccine in Malaysia as well as other countries. Yes.
Oh, okay.
Mm.
Okay.
I hope that's clear, yeah, Tanya.
Okay, Doctor. Let's see. We have another one question from Mr. Peter Lee. Would the origin recommend the type of vaccine based on their visits to them? My wife has not received any vaccination from the origin as yet.
Oh,
She's 32 weeks.
right.
Mm.
So this DTaP and flu vaccination, okay, especially for DTaP vaccination, is kind of like newish, yeah. They started giving this vaccination starting in 2012 back in the UK and also in the US because there is when more evidence come up, okay. So for instance, in Kementerian Kesihatan facilities, KKM facilities, we give a tetanus injection, that is the T from the Tdap, to all pregnant ladies. So now in addition to the T, the tetanus, we are actually giving the D, diphtheria, and AP, pertussis as well. If you haven't received that, maybe you can ask your obstetrician about that. because it is recommended.
Miss Tanya Lee, just now, Doctor, she said it's very clear. Thank you for answering my question.
Okay, thank you.
Sorry, Doctor, okay, I think we can take one more last question, yeah, from Miss Vivian Lai. Just one more question. After taken COVID-19 vaccine, can the mummy still continue breastfeeding, or the mummy should stop breastfeeding for a period of time?
Okay, as for now, like I say, for lactating mother, breastfeeding, and pregnant mother, they don't do studies in this group of ladies. Okay, so I don't have a say, but basically for lactating and pregnancy, COVID-19 vaccine is not recommended.
Okay, okay.
But although if you read more, I cannot recommend because the KKM doesn't recommend. But if you read more into it, because it is mRNA virus, it is actually very quickly degraded. So let's say if you are taking this vaccine, it from specific reading, it actually has no transfer to breast milk. So that's what I can only say. But so far, KKM doesn't recommend breastfeeding or lactating, or pregnant mother to take it. Yes.
Okay, thank you so much, Dr. Elena. So, okay, if you guys still have questions for Dr. Elena, can still type in the comment section and we will answer after the talk finish. For now, thank you so much, Dr. Elena, for your time.
Okay, thank you. Hope you enjoy my talk.
Everybody is saying thanks to you for answering the question.
All right.
Yeah,
Okay. Thank you.
thank you,
Have a
Dr.
nice
Elena.
day.
Bye-bye. For every participants, don't forget to fill in your details in a simple Google form attached in the Facebook comment section, yeah, for your attendance. So we will proceed with the next doctor after this, which is Dr. Melanie Majaham. She will be speaking about breastfeeding topic. While waiting for her, okay, Dr. Melanie is ready. Without further ado, let us welcome Dr. Melanie Majaham, our consultant pediatrician, to share about an interesting topic, which is breastfeeding is best feeding. Hello, Dr. Melanie.
Hi,
Hi, how are you?
I'm okay. How are you?
Good as well. Okay, Dr. Melanie, without further ado, let us proceed with your talk today.
Okay.
Maybe you would like to introduce yourself first, Dr. Melanie?
Okay, thank you for having me on board. I'm Dr. Melanie. I'm a consultant pediatrician at Sunway Medical Center Velocity. I'm a resident consultant here. So I'm a mother of two. Both my children are age 15 and 13 respectively, and I went through a lot of struggles during breastfeeding. So I often try to take as much time as I can to share whatever knowledge I have about breastfeeding, and I'm passionate about it.
Okay. Hey, Dr. Melanie, we can
Yes.
proceed with the talk.
Okay. So do I get to control the slides?
It's from my end, Doctor. It's okay. Doctor would like to go to which slide now?
Can I control the slides?
It's from my end.
I see. That is going to be a little bit complicated. But anyway, it's not possible, is it?
Yeah, it's not possible for now, Doctor.
Okay. So can we go back, please? And another time, and another one? Yeah. Another time? Yeah. Okay. All right.
Yeah.
Okay, next slide. Okay, so this is my breastfeeding journey. I have two boys. I also struggled with breastfeeding. For the first child, I breastfed for 13 months, and for the second child, I breastfed for 19 months, and they're really big now. It's a struggle that I empathize with a lot of parents. So I hope that whatever I share today will be able to help somewhat, even though at the end of the day, you have to, experience it yourself before you actually can sort of acknowledge the kind of problems or you're likely to face, and also to, experience the joy of breastfeeding. Okay, next slide. Next slide. Okay. Right. I think you skipped a slide. Okay, so all mammalians actually breastfeed, and it's quite strange that only in humans that that we opt to supply our babies with other options like cow milk and goat's milk. Next slide, please. Sorry, for whoever's watching, I have a lot of animations on this slide. It's going to be a bit, hopefully it will run smoothly. So next slide. All right, exclusive breastfeeding worldwide is something that's not as much as often as we want to. Only about 40% in general actually exclusively breastfeed. Next slide. And in Malaysia, this is not a very up-to-date data, but according to the National Health and Morbidity Survey, until 2006, only about 14% of Malaysians actually exclusively breastfeed for 6 months. Next slide. All right, what is exclusive breastfeeding? Baby is given only breast milk. So next slide. So when you are exclusively breastfeeding, we advise you not to give any water or formula. However, next slide. We can give oral rehydration salts, medicine, as well as vitamin drops. Next slide. So the outline of my talk will basically go through why we breastfeed, how does the breast look like on the inside, how is breast milk produced, how do we recognize when the baby is hungry, various breastfeeding positions, how do we know if the breast milk enough, and some common problems that are commonly encountered, as well as how to store breast milk. So why breastfeed? First of all, I'm sure all of you are aware of what colostrum is. Colostrum is basically the first milk, or what is called liquid gold. It's low in fat, high in carbohydrates, high in protein. It is easy to digest. It is a natural laxative, so when the baby starts colostrum early on, it helps the baby to pass the first stools early, or the first poop, to reduce jaundice. It has natural antibodies to protect the gut. It contains protective white cells, and it also contains natural prebiotics that basically help with the gut health of the baby. So a lot of studies have shown that breastfeeding actually reduces the number of obesity in children by 10%. And it also has a protective effect against type 2 diabetes. It has natural sugars like prebiotics. So the natural prebiotics actually help the baby to produce more of his or her own probiotics. And a lot of studies have shown that exclusive breastfeeding helps to reduce respiratory infection, diarrhea, ear infection in the first 6 months of life. So are there any benefits for mom? It also is shown to protect from breast cancer, ovarian cancer, and heart disease. And in the post-delivery stage, if you breastfeed, you will produce a hormone called oxytocin that actually helps the uterus to contract faster. So you will probably, at least bleeding will stop earlier as well. There's also, it also helps with faster weight loss because of the all the calories that you take in, a lot of it will be used to actually produce the breast milk. These are actually how an example of a 500 kilocalorie meal looks like. This is probably only one of it, not all. So you're supposed to add at least 500 kilocalorie in your daily diet if you're a fully breastfeeding mom. And if you are exclusively breastfeeding, it can also act as a natural contraceptive. But you really have to be exclusively breastfeeding at least 8 to 10 times in a day and no supplementation at all. It's also very environmentally friendly because you do reduce packaging, transport costs, and waste if you are fully breastfeeding. And finally, you will also save cost because it is essentially free. Next slide. Okay, next slide. So all about breast. So when you look at the ladies, at a breastfeeding mom, how does the breast produce breast milk? So there are various parts in the body. There is muscle, fat, ligaments, glands, ducts, nipple, and the areola. So all of these parts of the breast actually play a role in sustaining breast milk. Next. So inside the breast there is this tissue that actually is responsible for producing milk. Okay, so these are the parts in the breast. So there is the muscle cells which surrounds the milk secreting cells. So basically the breast will produce milk, and then after that it will come out from the milk duct, which is like the tube, and then subsequently it goes to the nipple, and then the baby will feed on it. Next slide. All right, next slide, next slide, next slide. So breast milk is all about supply and demand. Next. Okay, so when the baby suckles at the breast, what happens is that the baby will stimulate the pituitary, which is a part of a gland inside the mommy's brain, and will produce two types of hormones, which is the prolactin and the oxytocin. So prolactin is responsible for producing milk, and the other one is oxytocin, which is responsible for contracting the duct so that the milk comes out and goes into the baby's when the baby feeds on the breast. So basically this is a supply and demand concept. The more the baby feeds, the more the milk supply. So it's very important to realize that from the very beginning, if possibly from the first hour, try to get the baby to the breast, and subsequently every 2 hours, at the most 3 hours, to stimulate the breast. Okay, next slide. So it's very important for us to recognize early hunger signs. A lot of the times we wait for the baby to cry, and then when the baby cry, and then we try to feed the baby, because of the slight delay in the breast milk letdown, so the baby will scream and get really angry. So it's actually better to try to get the baby to feed when you start to recognize the early hunger signs, such as sucking the fingers, sucking the blanket, licking the lips, and also rooting reflex. So rooting reflex is when you touch the side of the baby's mouth and then the baby turns to that side. So these are actually all early signs of hunger. So this is the point that you should try to latch on your baby. Next slide. Because if you wait for the baby to cry and start moving the head, and when it gets really angry, it is really it's near impossible sometimes to latch a baby on. So you should always calm the baby down first. Okay, so breastfeeding positions, there are many. I mean, obviously, the average mom will not be breastfeeding in this position. So there are a few standard positions that I usually use. The first one is the standard cradle position. So this is a go back please. All right, this is the cradle position. This is what most moms are comfortable with. And then the next slide. And then this is a cross cradle position. So if you notice in the cradle position, the mummies, can you go back to the previous slide, please? Okay. So in this position, the mummy is feeding with the right breast and she's holding the baby with the right hand. So in the cross cradle position, it's the opposite. So the mom is feeding the right breast, but she's holding the baby with her left hand, with her opposite hand. So in this position, it helps a lot to latch the baby on, because sometimes if we hold the baby in a cradle position, sometimes if the baby leads the latch on, sometimes the baby will grab the nipple and cause pain. So a cross cradle position helps in certain situations where where the mom has sort of a better control to latch the baby on. Next slide. So this is a football hole. Football hole, basically the baby is under the mom's armpit, and the baby is being held by the mom, and then she's also controlling the latch on. So this is very helpful for women with sort of larger, heavier breasts, and also if you just had a cesarean section, so the baby doesn't press on your wound. And then next slide. And this is the side lying position. So side lying position is usually for bigger babies. When the baby is a newborn or small baby, sometimes it's a bit hard to feed in this position. Okay, next slide. So when you want to latch on, usually at first we tease the baby by holding the baby and bringing the baby's nose to the nipple. And finally, you might want to tickle the upper lip with the nipple a little bit. And when the baby's mouth is wide open, then you sort of like, with your hand, bring the baby to the breast as fast as you can, so that the baby takes up a big portion of the breast. Not just the nipple, the baby should actually also suck around the nipple, including the areola or the dark area around the nipple. Next slide. So this is what a correct latch on, an ideal latch on would be, where the baby's mouth is wide open. Sometimes we describe it as fish mouth. Next. Okay, there should be no dimpling of the cheeks. If possible, as much of the areola is inside the mouth, preferably the lower part of the areola. And the baby's tongue should be in between the lower gum and the breast. Okay, you should hear the baby. The baby should be relaxed when she's sucking, sort of very rhythmic, slow, and relaxed. You can hear the baby swallowing. You shouldn't have like dimpling. You know, the baby's mouth should not be going in, and you should not hear like clicking or sounds, because that means the baby's only feeding on the nipple only. Usually if the baby's latch on properly, you don't hear much sounds actually. Next slide. So I want to draw some importance to the first hour when the baby is just born. We try to practice skin to skin contact, belly to belly, because this is found to improve the success rate of breastfeeding and also infant survival rate. Of course, if there are any complications, or if sometimes if the mother is undergoing cesarean section, so there will be some limitations in this situation to do skin to skin contact. Next slide. So what are the benefits of the golden hour, the skin to skin contact? The mother's body actually keeps the baby warm. This can regulate the baby's breathing and the heart rate. and then it can cause the release of oxytocin, which actually reduces bleeding by contracting the uterus. When the baby is on the mummy's chest, the baby is exposed to good bacteria, and also if the baby successfully latches on in the first hour, then they can get all the benefits of colostrum, the antibodies, the vitamin A, and also of course it promotes bonding between the mom and the baby. Next. Okay, so a lot of the times the questions I get asked is when the baby is just born. Usually most moms will be worried because there is no milk at first. So the first 3 to 5 days, you don't always see the kind of milk like how you see in a box. You know, it won't be the white watery kind of milk. You'll just get a colostrum. So colostrum is a bit sort of like syrupy, a bit oily, a bit yellowish, but it is full of benefits for the baby. So it's very important to feed the baby frequently at the first couple of days. And then subsequently the milk will become transitional milk, and then it will proceed to become matured milk, which is how, you know, the kind of milk that you are familiar with. You will have fore milk, which is when, let's say if you're pumping, you will notice the initial milk is very watery, and then towards the end the milk becomes very thick and creamy and high in fat. So a lot of the times, you know, most moms will ask, how do I know if my baby is getting enough milk? Because unlike, you know, obviously if you are bottle feeding, you can see exactly how many ounces you are giving. But if you are directly latching on, a lot of moms sort of feel very worried if their baby is getting enough. So I think this is a very familiar picture that we see on the internet, whereby there are a lot of breastfeeding websites that says that on day 1 the baby's stomach is about 5 to 7 ml, which is the size of a marble, not the small marble, the bigger marble. And then by day 2 to 3, the size will resemble the size of a ping pong ball, which is about 1 ounce. And then subsequently by day 10, the baby's stomach will be like the size of an egg. So there are a lot of concerns from moms about whether you are overfeeding your baby. So for breastfeeding per se, I think this chart was shown to a lot of mothers to also to let mom know that, you know, your colostrum is enough, provided that you give it very, very frequently. That means sometimes even every 1 hour at first. So it can be really tiring. But I just want to draw your attention to the fact that the stomach capacity doesn't equal the calorie requirement of the baby, because the stomach does eventually stretch, and actually there is not much studies or not much scientific research that was actually carried out to really measure what is the size of the baby. So this is sort of an estimate. Next slide. So a lot of the times, parents are very worried about whether the milk they are giving is enough. Now, having said that, because the first few days the baby's stomach is really small, you do need to feed the baby very, very frequently in order to make sure the baby have enough calories and to maintain the baby's sugar. So for example, just to give an idea, 1 ounce of milk, or 1 ounce is 30 ml, is actually equivalent to 20 kilocalories. So the baby's requirement is about 50 to 100 kilocalories per kilo per day. So for example, if your baby is 3 kilos, the minimum requirement would be 50 times 3, about 150 kilocalories a day. So that is equivalent to about 225 mils of milk a day. So if you divide it into, let's say, every 2-hour feeding, that is about 20 ml for a 3 kilo baby on the first day. If your baby is not comfortable with that amount and can take only 10 or 15, then you probably have to give the baby more frequently, maybe even in the next hour. So there's no science, no exact science on feeding the baby. A lot of times you have to, go with the baby's cues. and also the baby's comfort. And but if the baby is jaundiced and sleeping too much occasionally, I mean, actually you need to wake the baby up to feed baby. Next slide. So like I said, there's very little studies to show what is the size, but the recent 6 articles of very, very old studies were actually, some are fairly new, using ultrasound and various or even autopsy of a baby who has passed away. They've sort of found out that about 20 ml is the stomach capacity. So maybe the marble, you know, the size of the baby being a size of a marble is probably not that accurate, and it's not for all babies. Some of the studies actually shows the size of the baby can be anything between 5 ml to 30 ml. So it can be at any, I mean, it can be a range. So you have to be very careful when we limit the baby's feeding deliberately. Okay, next. So having said that, once you fed the baby, especially if you are directly breastfeeding, how do you know whether the baby is has had enough? So usually by the 3rd day or so, when your mommy's milk start to come in already, a lot of the time there's no like real objective way to know. So after feeding, the baby will look satisfied, the breast feels softer. You can judge by the number of pee and poo that the baby is having. For example, by the third day, the baby should be pooping 2 to 5 times a day, or peeing 5 to 6 times a day. And also, you would want to make sure that your baby is feeding at least 8 to 12 times a day, between 1 to 3 hours. The feeding session can easily be 10 to 20 minutes, or even 40 minutes to 1 hour. And of course, a good weight gain is actually one of the most important indicator of adequate breastfeeding. So it's normal to lose weight on the first week. So don't worry if, let's say, in the first week, maybe your baby was born 3.2, and then when you went for your day 3 or 4 checkup with the pediatrician, and you noticed the baby lost about 10 or 20 grams. So it's actually normal to lose a bit of weight, but most of the time you lose between 3 to 5%. If you start to lose more than that in the first week, then we have to be very careful on whether or not whether or not the baby is feeding adequately. Next. Another thing that's really important is that don't use pumping as a way to determine if your milk is enough, because you know your body has gone through a lot of stress after delivery. So sometimes your breast might be full of milk, but then when you pump, only half an ounce come out, or even only 1 ounce, and then that will, you know, make you feel very discouraged, because you say, like, you know, how come I pump, I only get so little milk? So that's when a lot of women resort to formula. So at the end of the day, your baby is the best pump. So I have a lot of patients who sometimes, you know, the breast is so engorged already, and then when they started pumping, nothing comes out. But when the baby is latching on properly, they realize the breast empties a lot faster and gets softer a lot faster. So because the baby is sort of like more organic when the baby, you know, when the baby suckles, they are more effective at emptying the breast than when if you use a pump. A lot of pumps, they don't work very, very well compared to a baby, unless you're using a hospital grade pump. So jokes aside, so the first 2 months can be very challenging for breastfeeding moms, because of the size of the baby's stomach. You'll find yourself constantly feeding the baby. That is pretty normal. So how do you store breast milk? Usually once the 2nd week or 3rd week is up, or late, even earlier if you manage to start regularly pumping. So different temperature and different storage facility will actually determine how long you can keep your milk. So in room temperature, about 19 to 26 degrees, you can actually keep it for 4 to 6 hours. And then for a single door fridge, if you put it underneath, you can keep it for about 72 hours is safest. Next. So if it's a single fridge, it's about 2 weeks on the top. And if you have a double fridge in the freezer, you can keep for 3 to 6 months. Can you go back to the previous slide, please? And then for a deep freeze, you can keep for about 6 months. Okay, next. So store the milk in small amounts. Don't mix. That means if you just pump now and then 2 hours later you pump again, try not to put it all in the same storage bag. Don't reheat with a microwave. You can soak the bottle in a bowl with hot water, or you can use a bottle, the milk warmer. But once you thaw the frozen milk, you should use it within 24 hours and do not refreeze it. Next. So there are some common latch-on problems that moms commonly face. So I think this is one of the commonest things, cracked and bleeding nipples, and this is usually related to the latch-on. So a lot of times, mummies the baby's mouth is not adequately open when the baby is latched on. So the baby is just sucking on the nipple. So this can actually cause a lot of injury and pain. Next. Engorged breast, especially in the first 3 to 4 days. This is because at the beginning the body is overproducing. It hasn't matched the baby's requirements. So the initial part, your breast can be very congested, but if you don't empty it adequately, then it can be engorged, and you need to empty it. Otherwise, it will be very painful. You can also develop mastitis, which is actually infection, and this one usually starts off with engorged breast and leads on to blocked ducts before being infected. Sometimes the baby will have a white patch on the mouth, and then it's a yeast infection. And then when you treat the baby, you have to also treat the mom, because the mom can also have a yeast infection. So looking at several problems, sometimes because nobody is built alike. So some breasts, sometimes the nipple are a little bit flat or a little bit inverted. So all this situation can actually be very difficult for the baby to latch. So because every individual is different, for this kind of this sort of moms, if they face these problems, then you probably need to see a professional or lactational consultant to actually assist on how to go about feeding your baby. Nipple shield is controversial. It works for some. I have had a few patients who have fully breastfed with a nipple shield and the child is growing well, but you do need to use it with supervision, because sometimes the milk letdown is not as good as if the baby's latch on directly. So there's a top-up trap that most of us fall into. Sometimes you feel like you're not making enough breast milk, and then we top up with formula. And then when the baby feels like too full and sleeps more, then the baby will suck less at the breast. And when the baby suckles less, then there's less demand, so the body will produce less. And then eventually your milk supply will reduced to a point that it's not enough to feed the baby anymore. So this is actually a very common problem. So keep calm. I hope that your breastfeeding experience is something that's beautiful and joyful. But I think the most important thing is that read a lot, watch a lot of videos, really get immersed into how to make breastfeeding successful, so that you are both better mentally and emotionally prepared to handle the initial stresses that comes with breastfeeding. Having said that, I myself went through a lot of problems. I also saw a lactation consultant. It was a struggle, but looking back, I think that is something that if you can breastfeed your baby, it is something that you will be proud of, because but don't at the end of the day, it's a personal choice. A lot of us are working moms, so sometimes we have to go with the flow and see what best suits your lifestyle and your personality as well. Okay, so this is actually my references. So I want to draw your attention to one very good website. It's called Global Health Media. It's the second from the bottom. Just Google global health media, and there's some really beautiful videos on breastfeeding that really, like explains better than what any slide can explain, and really shows how to latch a baby on and the common pitfalls. Just go to global health media. I really encourage you to look at those videos. Okay, thank you.
Thank you, Dr. Melanie. We have one question here before we let you go. So this person asked Dr. Melanie, is it advised to do mammogram or ultrasound during breastfeeding?
During if it is just a normal breastfeeding situation, a breastfeeding condition, it is not actually necessary to routinely do an ultrasound mammogram at that time, But for example, if there is an unusual lump, or there is there is unusual discharge from the nipple, puckering, or is some changes in the breast skin, any concerns at all that you may think that whatever lump or whatever thing you are feeling at that time is not related to breast feeding, then you do need to probably proceed with an ultrasound, or even not a mammogram, usually an ultrasound.
I see. Okay, Doctor, we have second question here from Mr. Peter Lee. What's the reason of some mothers facing clogged milk duct? And how to ensure it's not clogged or treat a clogged milk duct, Doctor?
Okay, clogged milk duct is actually kind of common in all breastfeeding moms. So massaging it and pumping regularly, or even feeding the baby while you massage, can help to unclog. Sometimes a warm pack, a warm compress before you pump or feed can also help. Certain supplements like lecithin can also help to unclog milk duct. If there is any further problem, then if it causes further pain or it's not getting better, then you do need to seek help from a professional. Yeah.
Okay, thank you so much, Dr. Melanie, for answering the question, and also thank you for your time for the very informative talk. I'm afraid this is the only time that we have today, Dr. Melanie. Thank you so much for your time.
Okay, thank you.
Okay, thank you. We will proceed with our fourth and last speaker for today, which is Dr. Hasmawati. Dr. Hasmawati is our consultant pediatric and neonatologist, and she'll be sharing about the amazing journey of a premature baby. Okay, while waiting for Dr. Hasma to join. Hi.
Hello.
Hi, Dr. Hasma. How are you, Dr. Hasma?
Still alive?
Okay, Dr. Hasma, I think without waste so much time, let us start with your talk today. Maybe you'd like to introduce yourself first, Dr. Hasma?
Okay, I'm an old person. I'm a neonatologist. Retired from the government. I'm in an university because I need this hospital open an NICU, neonatal intensive care. So they want my help. So I'm here to do what I can do to help this hospital in babies, in having babies, problem babies that needs intensive care. Okay, so one of it is actually premature baby. And frankly speaking, mummies, if you my message to you before starting this is that try to make sure that you are healthy, and well, and try to make sure your pregnancy is up to term. Okay, but unless it's unfortunate they have few diseases, then you might get a premature baby. But don't worry, you need to know something regarding premature babies, because that only then you can handle them very well. I have just sent a 1.1 kilo baby to Hospital Ampang. That baby was born here about 2 weeks ago. For 1.1 kilo to reach to a weight of 1.8 kilo takes about 1.5 months. So to be born in a private hospital is very expensive for a 1.1 kilo baby. So we have to send the baby to a government hospital where it's much better to stay there, because in terms of money wise, you mummies will have a lot of difficulty in paying in the private hospital. So can we proceed with our slide, second? Okay. What is actually, we start off with low birth weight baby. It's babies that are less than 2,500 grams. So they can be a term baby or preterm baby. So any preterm babies are usually those babies that is less than 37 weeks. They can be small or large or appropriate for gestation. Okay, but there can be a term baby also who is less than 2,500 grams. Okay, but we will concentrate ourselves on these preterm babies. Next slide, please. Okay, so all the definition of preterm baby are those babies that's born less than 7 weeks. We categorize them in low birth weight baby if they are less than 2,500 grams, or very low birth weight baby if they are less than 1,500 grams, or extremely low birth weight baby if they are less than 1,000 grams. And they can be SG if is less than 10 centile of their birth weight. Next slide. Okay, all over the world, it's a problem when a preterm baby is born. Okay, we are actually the third highest, the Southeast Asia, the third highest in terms of babies born preterm baby. So they are considered as baby born too soon. Next slide, please. And why is it common in developing countries? There are a lot of reasons. In Malaysia itself, about 12.3% of all deliveries are preterm baby. And yearly, about 500,000 roughly figure. And the figure is that out of, for 2015, about 24% of this live birth are preterm baby, less than 32 weeks. And 27.3% are less than 1,500 grams. Next slide, please. Okay. The problem is that I know it's scary to tell you, but these small babies have a higher risk of death. Okay? And they account for 80% of neonatal death. And they are risk of long-term complications. So that's the reason why if this preterm baby, we just hear a preterm baby, we know that they need to be in a center where there will be a specialized care by highly skilled team of healthcare professionals. Because for these babies, it's not just enough to survive. You need them to thrive. You need them to grow up so that they can go home safe. Okay, next slide, please. Okay, so when a baby is born, preterm baby, I always thought that this baby will tell you, parents, mommy, daddy, that they came out too early. They're very sorry, but what they want from you is actually your support. Come every day to see your baby who is preterm, so that they know that you are there to strengthen their emotions, so they can grow, and they need your help. So please, if you have a preterm baby going to be delivered, but hopefully no, you will be there to support them. Next slide, please. Okay, the reason now you need to ask a few things. When a preterm baby is going to come out, impending preterm labor, we doctors always ask obstetrician, is the mom in active preterm labor? Is there any reason why these things happening? Is the obstetrician going to give steroid to the mom to help to mature the baby's lung? Or are they going to try to stop uterine contractility? Okay, is there any risk of infection in the mom or baby? And the final question is how the baby is going to be delivered. Okay, there was 2 weeks ago. There's a Gravida 3 para 2 mom came in at 29 weeks. Okay? 29 weeks with 1 kilo. We try not to get the mom to be delivered in a private hospital. The reason is because it's expensive. Okay, but so what the obstetrician did was try to stop the uterine contraction, but unfortunately it progressed. The baby was born 1.1 kilo, so we managed the baby, but in actual fact, this mom should be transferred to a government hospital when it's 29 weeks or 30 weeks. But unfortunately, at that time, there was a Chinese New Year. Remember the Chinese New Year? The government hospital are very full. They have a lot of problems because everybody is delivering before Chinese New Year. So what happened? We cannot send the mom in utero because the best place is definitely we have all the equipment, but we know that for this baby to grow up to 2 kilo, it takes a long time. So it's better to be a place where it's much cheaper. Frankly speaking, I have to say that out. Okay, next slide, please. Okay, so when a baby, when mom goes to preterm labor, usually we need to find what is the reason. And usually, if mom have some diseases like hypertension, diabetic, heart disease, kidney disease, or infection. Okay, for a baby, usually if you have a twin pregnancy, the risk of getting preterm labor is about 15%. Next slide, please. So other than that, other risk factors are if you are teenage pregnancy, less than 80 years, or you are stressed, you have some problems, socioeconomic status are not good, you have poor nutrition, you are doing some substance abuse, okay, and other history of preterm delivery, abnormalities of the uterus or cervical incompetence, or antepartum hemorrhage like placenta previa, abruption placenta, all these are risk factors for you to have a preterm labor. Okay, for us is we have in terms of statistics we are a bit higher than USA. USA about 10% are preterm baby, and we are about 12.3% in Malaysia are preterm baby. Next slide, please. Okay, so the concept for a preterm labor is actually to prevent it, because we know that whatever is, we need to try to get mom to have a term baby. So prevention, prevent. But if there's a problem that we cannot prevent and the baby comes up preterm baby, then we need to manage this baby holistic approach. Okay, manage whatever the complication that arise. Okay, treat the disease, and we need to screen the baby, like doing ultrasound, eye check. We need to make sure the nutrition is good. Okay, Dr. Malini has already spoken to you regarding breastfeeding, because the nutrition for the baby, preterm baby, is actually breast milk. Okay, that's the best milk because it helps the baby in terms of the nutrition. Okay, doing kangaroo care is also part of it. We'll explain to you later. Okay, so the role of parents is actually come and visit. So if you have a baby who's preterm baby, visit, give some support, give encouragement, just touch your baby, because it's important of this emotional bonding. Okay, and when the parents come, always be sensitive regarding infection, because the baby has a poor immune status. Okay, poor immune. So wash your hands. Try not to wear any watch or any rings while touching your babies. Okay. If you are having some illness, wear a mask. Especially with the COVID thing, it's better to wear a mask. Okay? And bring in breast milk. Okay, you express your breast milk. If the baby cannot suckle, and if the baby can be breastfeed, we will encourage you to breastfeed the baby if the suckle is good. Okay? And in the same time, please do kangaroo mother care. Okay, this is skin to skin contact to improve the baby's warmth, weight gain, and the developmental. Next slide, please. Okay. To prevent, what do you do to prevent? When you, mommy, if you are pregnant, first time you heard you're pregnant, start your antenatal care. Okay, as early as possible, because early and good prenatal care will actually reduce incidence of prematurity, all the small babies. Okay, and the morbidity, deliveries, and the neonatal period. Okay, so when you come to us in a preterm labor, the obstetrician will try to stop, because we do not want you to give a preterm labor. We will try to stop your preterm by reducing your uterine contraction. What is the reason? We will need the baby to be in utero. Your uterus is the best place for a baby to build up, to become term. Okay, so we need the baby to be in your uterus. Okay? And other than that, make sure you have healthy nutrition, healthy weight gain, gain the amount of weight during this pregnancy. Please do not smoke, do not drink alcohol, or use any drugs. All this is such actually reason to get a preterm baby. Next slide, please. Okay. If you have chronic illnesses, treat them. Okay, treat your hypertension, treat your diabetes, protect yourself from infection, take vaccination. Okay, the obstetrician will tell you what vaccine to be taken. Okay? Reduce all your stress, and please space out the pregnancy. Okay, at least 18 months between giving birth. Okay? Use birth control. To make sure you're ready to get before you're pregnant. Okay, if you're older, or if you have any miscarriage, these are risk factors that you're going to get a preterm baby. Talk to your obstetrician how to wait between this pregnancy. So all these are prevention, because prevention is better than to manage a preterm baby. Next slide, please. Okay, so if you have already tried to prevent and yet, because if chronic is usually is either multiple pregnancy or you have diseases, then your baby might come out as preterm baby. Okay, okay. We usually will not. We are always scared if the baby is less than 32 weeks or less than 1.2 kilo. Okay? Because they're small, they're very small, they have a lot of problems. They have problems in terms of breathing because the lung is not matured and the muscle of the respiratory are weak. Okay? So they need to be inserted a lot of tubes to be connected to machine to help them to breathe. Okay? And some of these babies might not survive, okay, because they're too ill. But don't worry, they are there to help you when you are in afterward. Okay, next slide, please. Okay. Because premature baby, they have a lot of problems that they are going to face. One is feeding difficulties. Okay, like that baby I was telling you, 1.1 kilo. The initial problem is feeding difficulty. The first 2-3 days, mom doesn't have any milk, so we have to try preterm formula, but that doesn't work. So we just keep on telling mom, please come bring in breast milk. So she did bring. Only then the feeding was good. Okay? We have to support the baby because the lung is not good. The lung has the baby has mild RDS. So we're giving a non-invasive technique of ventilator for this baby while waiting for the baby's weight to grow up. Okay, the first 1 week the baby's weight will come down. So we need to while waiting for weights to come up, we need to support the baby in terms of giving machine technique, non-invasive technique, and at the same time give nutrition, and the nutrition is breast milk. Okay, and then that the baby develop jaundice, we put the baby on the photo. Next slide. So these are the reason why reason why the baby will have some problems: feeding difficulty, RDS, jaundice, anemia, the eye, the feeding tolerance, okay, and infection. Next slide, please. Okay. Other than that, they can become cold, hypothermia, can have low glucose, hypoglycemia, breathing apnea, short stop breathing. They can have heart disease, intracranial bleeding in the brain, infection, bone diseases, and chronic lung disease. So we are going to talk a bit about all the diseases. Okay, next slide, please. Okay, but before this thing happen, there is such a thing as golden hour. Like even Melanie is telling you about the golden hour, because that is actually in the labor room, where if the baby's preterm is come out, the first 1 hour is very important to optimize so that the subsequently the management of the baby is much better. Has a long-term implication. Next slide, please. Okay, so if a preterm labor cannot be stopped, the baby needs to be in an area where there is an intensive care unit. So in our hospital, Sunway University, we have an intensive care unit. Okay, so we have all this where you have this incubator, okay, the warmer, and we will anticipate problems and manage accordingly. So when the babies come out, we will get the baby using from labor room to NICU using a pre-warm transport incubator. So the first thing we need to do is that making sure when baby comes out, the baby is warm. Okay, next slide, please. Okay. So all these babies require initial assessment. So when baby comes out, see whether the baby is breathing good or not, okay, whether the baby is crying well, okay, and whether the oxygen is good, okay, whether the oxygen is the baby is pink or not. And if baby is pink, if not pink, then we need to give some oxygen supplement and making sure the baby's saturation is between 85 to 95. So the initial step is actually to resuscitate the baby. Next slide, please. Okay. And the warm is very important, so that you need to can we click at the video? Okay. Okay, so this is what happened. A very small
Use scissors to make
kilo.
closed
The baby
end.
comes out, we actually put the baby in a plastic polyethylene bag. Okay.
Then, after the baby has been placed in the
And
bag
just bring out the head only
and the
and
baby
do some suction. Okay.
resuscitated,
Why are we putting baby in plastic bag, polyethylene bag?
might further
Maintain
evaporate.
the warmth of this baby at birth. Okay. While even there's a preheat radiant warmer, but this is very important for the small baby. Next slide, please. Okay, so that's for warm. And subsequently, we examine the baby, check the heart rate, the temperature, the blood pressure, and see whether the baby has problems or breathing tachypnea or temperature is low or apnea. Okay, and we do a chest X-ray, blood gas, okay? Check the glucose and food blood count. So these are things that is done for this baby. Next slide, please. Okay. And we do this pilot scoring to see how pram the baby is. Okay. If you tell us that baby is 36 weeks, and we found that the baby is very small, and when we do this pilot, it's actually 32 weeks. Oh, that will be a problem to us, okay, because the baby is small. Okay. Next slide, please. Okay, so from there, from a labor room, we will transfer the baby in a transport incubator, which is also warm, and bring the baby to our NICU. So we have a closed incubator, and even the closed incubator is actually on the left side, and the open incubator is on the right side. Okay? So these are equipment to make sure the baby is in a warm environment. Okay? And to maintain the temperature between 36.5 to 37.5. And this is what we call thermoregulation of this baby. Okay, next slide, please. Okay. And other supportive measures will be all these baby will put on drip, because usually when they are very small, especially small baby, the sucking is not good. So usually we do not feed them while waiting for mom to give express breast milk. So this baby is on 10% dextrose, which has enough calorie, and we will see what else we should do to sustain, whether they need some saline, if they have blood pressure is low, and all these baby are usually started on some antibiotic, which is penicillin and gentamicin. And the concept is actually keep the baby warm, make sure the baby's glucose is good, and if the baby is very small, the skin, the fragile skin are maintained. Okay? And subsequently, we treat the disease related to the prematurity of this baby. Next slide, please. So this is one of the diseases where, because the lung is immature, they have a reduced surfactant. So in other words, the lung are all collapsed. So if you see the X-ray, it's all wiped out. So one of the treatment for this baby, we give surfactant where it's deficient, and this surfactant when we will infuse through our tube into the lung, ETT, the tube which goes to the lung, will actually mature the lung. Okay? While waiting for this thing to happen, we will actually assist this baby by helping the baby to breathe using a machine, okay? A ventilator machine. So this is actually supposed to be prevented if mom is given steroid while waiting for the preterm delivery, while preventing the preterm delivery. Okay, so usually mom is given steroid to prevent this problem. But if not, if it doesn't, even if mom given steroid and yet the baby come up premature and this hyaline membrane disease is still there, then we will give this surfactant. Next slide, please. Okay, so we're giving this surfactant which mature the lung from the white lung now on the left side now becomes a normal lung on the right side. So it happens I always say that this surfactant is called the miracle drug for a preterm baby because it actually treats the disease, fine membrane disease. Next slide, please. Okay. Subsequently, all these baby are monitored. Continuous monitoring of this baby, the machine, the blood gas, the cardiac monitor, and the nurses need to be skilled to manage this small baby. Okay, such as done while needed if there's lot of secretion, we need to do some chest physio to help the baby because they cannot breathe, they cannot cough out. So all this is done by nurse, and the nurses usually have a post basic in neonatal care. Next slide, please. Okay. Unfortunately, if it's a very bad RDS, okay, hyaline membrane disease, this can evolve to a disease they call it chronic lung disease, especially if the setting of a machine that helps a baby is using high pressure, the oxygen given to the baby is quite high. So all this can actually create a lot of problems to the baby. So we do not want this to happen to preterm baby. But this thing does happen if whatever we are doing is giving whatever they are doing is not able to be successfully treat the RTS. So this is chronic lung disease at the age of 5 months. Next slide, please. Other problems in baby when that baby's breathing is not good, they tend to stop breathing and heart rate drop. This is what called recurrent apnea because of this immaturity of the respiratory center in the brain. Okay, so when this thing happen, we try to support the baby using machine, okay, to have the baby to breathe. And there's a drug they call it caffeine or theophylline to stimulate the baby's brain to get the baby to breathe. Okay, so this is apnea of prematurity. Next slide, please. Okay. The baby can have a heart problem, okay, where the connection, they call it patent ductus arteriosus. So this is where we balance in terms of our fluids and what the baby needs. Okay, so the baby can be asymptomatic, but if cause problem, cardiac failure, then we need to make sure the baby is given some treatment like fluid restriction, treatment to close this patent ductus arteriosus, indomethacin or Profen, or if it's very bad, then we need to do surgical intervention, surgical ligation. Next slide, please. Baby is common for preterm baby to have jaundice, so we tend to monitor. If this baby is starting to have jaundice, we straight away put the baby on phototherapy. Okay, because for a preterm baby, the amount of jaundice can actually cause damage to the brain. So this is very important to monitor properly. Next slide, please. Okay. Okay, infection is one area where it's very important for us nurses, doctors, and even moms and parents to know that anything is possible to get bacteria to the baby. Okay, we just see a baby. The one that I was telling you stay with me 2 weeks had some loose lethargy, not feeding. We know it's already infection. Okay, stop breathing, apnea, or feel abdominal distension, all these tells you with infection. Okay, how to prevent it? It's always one of it is actually hand washing. So that's the reason why we always tell the nurses, please wash your hand before you touch a baby and after touching the baby. Even parents, please wash their hands before touching the baby. And the other one that helps the baby to fight infection are breast milk, because breast milk has antibody which can actually help the baby immune system to fight the infection. Okay, next slide, please. Okay, so these are pictures telling you how to go about doing hand hygiene, hand washing, okay, before touching the baby, after touching the baby, even while we are going to do procedure on the baby, we need to wash our hands. For moms, okay, even touching the surrounding of the baby, we need to hand wash our hands. Okay, next slide, please. Okay, one of the things that preterm baby tend to have is intracranial bleed. Okay, intraventricular bleed, intracranial bleed. They have a grade 1, 2, 3, 4, 5, and if we see that baby suddenly turns pale, okay, we usually know it's an intracranial bleed. But we also do a routine ultrasound of the brain, okay, for this baby, roughly around the first week to see whether there's intracranial bleed or not. And subsequently around 1 month to recheck again whether this bleed is causing problem. Okay. Next slide, please. Okay. Anemia is common, especially if we have sick baby and we need to monitor frequent blood taking. For 1 kilo, we are doing every day 2 to 3 times blood taking, then usually the baby's the hemoglobin will drop. So we tend to make sure we monitor this hemoglobin and making sure the hematocrit is more than 35. Okay? So if there's any reason that the hematocrit drop, then we need to transfuse PET cell for this baby. Okay? And all these baby are given some supplement. Okay, this is the time when preterm baby is where you need to give supplement. Iron supplement, by 2 weeks we start this baby on some iron supplement and continue for 3 to 4 months. Okay, next slide please. Okay, we also do eye check because when the baby comes up, preterm baby, one of the problems is that if you give too much oxygen to the baby, it can actually cause problem to the eye. So we are very cautious in monitoring when we give oxygen to this baby, especially at birth and subsequently in the ward, to make sure the oxygen saturation of this baby are maintaining between 85 to 95. If you're giving too long, it can cause problems. So usually all these baby will be have eye check for retinopathy of prematurity, and this is done at 4 to 6 weeks of life, okay, to see whether they have problems or not. Okay, so you see the right side is already very bad, stage 5. There's a staging on this, and the eye people, Dr. Fiona is our pediatric ophthalmologist, usually doing this thing, and the management is very bad stage, then you need to do some laser therapy for this baby. Okay, next slide, please. Okay, so for preterm baby, like I was saying to you, the best nutrition is preterm breast milk. Okay, so when a baby came out as a preterm, the mom's milk at that time are called preterm breast milk. The content of this preterm breast milk are totally different from a term breast milk. In what sense? The antibody are higher in the preterm breast milk. The protein are also higher in the preterm breast milk. So that's the reason why we cannot give a term breast milk to a preterm baby. But if we do not have any choice, then we have to accept the breast milk wisdom. So when a mom delivered a preterm baby, that is why we want the mom to give a preterm breast milk for this baby. Okay, but some mom, when they are panicking, they will try to get other moms to give breast milk. But the problem is that if that other mom has a term breast milk, it is not comparable with a preterm breast milk. Okay, so this express breast milk is very important for this baby to prevent necrotizing enterocolitis. Okay, this NEC happen when the baby have infection, okay, and we are using formula milk. Somehow the mechanism of it, the baby will vomit, and abdomen become more distended. So breast milk, EBM, help to prevent this necrotizing enterocolitis. Okay, next slide, please. Okay, so how do you give this milk to the baby? It depends on whether the baby is suckling well or not. Okay, the smaller the baby, you know the suckling is out. So you tend to give to rice tube feeding, and the interval is usually 2 hourly or 3 hourly. Start with a very small amount, 1 to 2 minutes per kilo, and increase gradually. Sometimes we need to infuse the milk, especially those baby that is less than 1,000 grams. Okay. While waiting for baby to tolerate feeding orally, we put this baby on total parenteral nutrition, which is intravenously. Okay. For all the sick baby, this is what we do, and this is given through our central line umbilical venous catheterization. Okay, so next slide, please. Okay. Feeding intolerance are very common. That's what I was telling you. The baby sometimes can vomit on you. Okay, abdomen distended on you. So it's a nightmare how to manage this baby. So, but we hope that if, by giving breast milk, this will be reduced. Okay, until we get a full established, because they can have refluxing. They have necrotizing enterocolitis, which is the nightmare of all these feeding problems. Okay, where you can actually, the baby can go perforation, like necrotizing enterocolitis, perforate, and we need to go in for surgical intervention. Necrotizing enterocolitis, the baby can die on us. Okay, next slide, please. Okay, what the total parental nutrition, which I was telling you, is actually the nutrition that's required for this baby given intravenous through IV while waiting for oral feeding to be established. Okay? The best form for nutrition is stay breast milk, but the small baby will need some time to get a full feeding with breast milk. So that is the reason why we need to put this baby on nutrition intravenously. Next slide, please. Okay, and the thing is that all this the parental nutrition has to be given via a very septic, sterile technique in giving to this baby, where the nurses has to wear gloves, gowns, and clean up the lines properly, so that they are given in a very clean way to this baby to prevent infection going to this baby by this technique. Next slide, please. Vitamins is some of the supportive measures that we usually give. Okay, iron is given at 2 weeks. Vitamin is also given at 2 weeks of life to help some of the things that some of the vitamins which are usually not there in a preterm baby. Multivitamin, folic acid, and while waiting. So all these baby at birth, the baby's respiratory is getting stable, baby is feeding well, everything's fine. Okay, we started vitamin at 2 weeks and we send the baby home. Okay, all this preterm baby requires a weight gain at least 15 gram per kilo per day. So for a 1 kilo baby to come to about roughly 1.5 kilo, it takes about 25 days. I was calculating that day for this my premature baby. Okay, and that's still a long way to go, because what weight do we send home this baby? Usually 1.8 to 2 kilo. Okay, it depends on whether mom is confident enough in taking care of this baby. So this baby are discharged roughly more than 1.8 kilo. Okay, and mom needs, before baby is discharged to mom must actually stay with us and stay with the baby for at least 3 days, so that the baby, mom knows how to handle the baby. But we always encourage a mom to come every day, touch the baby, do kangaroo mother care, which is another support of this baby. Next slide, please. Okay, this is kangaroo mother care, which is done for all this baby less than 2.5 kilo. It's a skin to skin contact, okay, for this baby. And that's the reason. Next slide, please. Okay, it's recommended for babies, especially after delivery, to ensure warm. But while in nursery or in an NICU, this kangaroo mother care is actually a skin to skin longer, prolonged. Roughly, we encourage mom to do it at least minimum is 1 hour. Longer, it can be 24 hours, but we tend to get mom to do at least 6 hours in our ward. Okay. It's a support to the baby and also to mom. Okay? And actually, it helps the mom to have a lot. When you do this, it helps to prevent infection. It helps the mom to the milk to be produced more. It helps the baby to get a lot of warm and reduce hypothermia and prevent death and infection. Okay, next slide, please. Okay, so it actually provides developmental care for preterm baby for at least 6 months and a full-term baby for 3 months. So all KMC is given to all those babies that's less than 2.5 kilo. Okay, but I encourage to any mom who is interested in kangaroo mother care to do it, even the baby is bigger. Okay, next slide, please. Okay, these are reasons why it's good. It reduces severe infection by 43%, reduce hospital infection by 58%, reduce hypothermia, coolness by 77%. Your breast milk will be a lot. Okay? The growth of this baby is better. Mom with this baby doing skin to skin will have a lot of love for the baby. The bonding is good, and helps the baby to go home a bit earlier. And finally, it reduces death by 40%. Next slide, please. Okay, so this is, can we click on the thing to start the video? Hopefully it works.
Yeah,
Okay, so hanging, is it? Oh dear. This video is just to show you guys how it's done, but I'm not. Okay. You can actually go to YouTube and just type kangaroo mother care. There's a lot of video on kangaroo mother care, how it's done. Okay. We actually have a kangaroo mother care association, KAMI, KAMY, in Malaysia. We actually created this. I'm one of the pioneer group in doing this thing for babies, for babies who's less than 2.5. So you see the moms when they tube, we have this under our association, KAMI, which is the office is in Penang. So you just Google KAMI, KMY, so you can see our association. Okay. So all these babies are subsequently discharged if the baby's health is good, feeding well, gaining weight, temperatures maintained, and mother and parents are confident in doing kangaroo mother care, and subsequently comes in for visit. So the criteria for discharge is weight at least 1.8 kilo for this baby, and subsequently we follow up to see whether the baby is gaining weight well or not. Next slide, please. Okay, so when a baby is going home, one of the things that parents need to know that their house is need to be clean. Okay, prepare the room where you're going to put the baby, okay, so that they will not have infection. Okay. They will slowly develop. Okay, don't worry. All they need is actually your love, your support in growing up. Okay. Be patient with your baby who is premature. They need a lot of support. But soon, I always feel that all these baby, when they come on my follow-up, they're always smiling to me, happy that they are alive, okay? They're alive. And after having all the challenges in their stay in an ICU, they are okay. Next slide, please. Okay, so what is the chance of a baby, preterm baby, to survive? It will depend how small they are, what is their gestation, what are the problems that they face in an ICU, what's complication. So the gist of it is that the smaller the baby, in terms of gestation, the smaller in terms of birth weight, the likelihood of complication is bad and the bad outcome. But in saying that, what we have gone through, all this baby, we can really smile when they come up to us on follow-up. They're getting better. Okay. So that, I think that's the last slide. Thank you. That's the last slide tak ingat saya ni. Next slide, Abi. Okay. Any questions so far?
Thank you, Dr. Hasma. Anyone, if the participants, if you have any questions, you guys can always type in the comment section. In the meantime, Dr. Hasma, maybe we can just ask can you share a bit of the tips to prevent premature, doctor?
For mummies.
Any?
Okay, mummies, you need to know that try not to get any diseases at least. Okay, hypertension, diabetes are all the risk for getting premature baby. Okay, and if you have a twin pregnancy, the risk is there. Okay, if you don't have these, don't stress yourself. Rest a lot. Okay, rest a lot. Don't stress yourself. Good nutrition. You need to have a healthy diet. Do not diet. I mean, if you want to diet in pregnancy, that's a bad way of doing things, because you need food for you and the baby. So don't diet in pregnancy. Okay, just eat healthy food so that the baby can grow. Okay, and don't stress yourself. Don't smoke. Don't do alcohol. Don't do drugs. Okay, it usually works. Okay.
Okay, thank you so much, Dr. Hasma, for your time today and for sharing the very informative talk with us all. Thank you, Tasma.
Okay, bye. Bye, Mommy.
Thank you so much. Thank you everybody for joining and staying with us until the end of this session. And don't forget to be sure to follow our social media account on Facebook and Instagram at Sunway Medical Velocity for more details and information on future events, promotions, and etc. We'd also like to take this opportunity to thank our sponsors, Sherab and also Pigeon, who sponsored us 50 free gifts for our virtual talk today. Stay safe, everybody. That's all the time that we have today. Thank you.